Thank you. Hello, good evening. Very much welcome to tonight's event. My name is Micha Nussbaum. I have the honor to welcome you to tonight's webinar, which is going to be on chronic lymphocytic leukemia, which is brought to us by the Mumbai Hematology Group. Roche has been invited as a sponsor, which we are very proud to be part of this event today. It will be moderated by Dr. B Agarwal, whom everybody knows. I don't have to say much. There will be a lot to say about Dr. Agarwal. I mentioned just a very few things. Dr. Agarwal is the professor and head of the Department of Hematology at the Bombay Hospital Institute of Medical Sciences in Mumbai. He's a consultant at Lilavati Hospital and Breach Candy Hospital. He's president of Mumbai Hematology Group, vice president of the Indian Society of Hematology and Blood Transfusion, past president of Indian Society of Hematology and Transfusion Medicine, a member of the selection committee of the Department of Pathology at the Tata Memorial Hospital. He has more than 140 publications, which I will not mention now, otherwise we would finish the webinar just doing this. And he's also an author and co-author of many editorials, books, and chapters. It is really a great honor for me to be part today of this meeting. I will be taking notice, I will be learning a lot. I'm convinced of that, and with that I would be happy to hand over to Dr. Agarwal. Thank you very much.
Thank you, Dr. Micha, for that kind introduction. I'll just share my screen. So good evening to one and all. Today our guest speaker is Dr. Jennifer Brown from Boston. She will be lecturing us on chronic lymphocytic leukemia. This webinar is brought to you by Mumbai Hematology Group, supported by Roche and managed by Mice Ideas. I thank Team Roche for supporting our academic activity, Mr. Rajesh and Kalpesh and the team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Jennifer Brown from Boston, all our discussants were themselves very eminent hematologists and medical oncologists from various parts of India, and you participants for sparing your Saturday evening. To introduce the discussants this evening, we have a galaxy of them. From Nagpur, Dr. Dilip Gohoka. From Ahmedabad, Dr. Sandeep Shah, Dr. Bhavin Shah, Dr. Akanksha Garg, Dr. Nidhi Jain, Dr. Aishwarya Raj. From Mumbai, Dr. Subhaprakash Sanyal, Dr. Bhauseh Bagal. From Srinagar, Dr. Afaq Ahmad Khan and Dr. Reshma Roshan. From Pune, Dr. Sweta Alankit and Dr. Aniket Mohite. From Surat, Dr. Amit Khurana. From Anand, Dr. Priyanka Srivastava. From Kochi, Dr. Deepak Charles, and from Madurai, Dr. Rajkumar Ramaswamy. Welcome to this webinar and to have a very interactive discussion with Dr. Jennifer Brown this evening. To introduce Dr. Jennifer Brown, she doesn't require any introduction. All of you are deeply into chronic lymphocytic leukemia and you know her contribution to this field. To complete the formalities, she's director of the CLL Center of the Division of Hematological Malignancies at Dana-Farber, and she's professor of medicine at the Harvard Medical School. She's completed a BS and MS simultaneously in molecular biophysics and biochemistry at Yale. Graduating summa cum laude with distinction. This is a Latin term and I had to do some research to find out what it means. It means that she had an extraordinary distinction in getting these qualifications. She proceeded to Harvard, where she received her MD and PhD in molecular genetics in 1998 and was awarded the James Stolbert Shipley Prize. She then served as an intern and resident in internal medicine at Massachusetts General Hospital, followed by fellowship in hematology and medical oncology at Dana-Farber. She joined as a faculty Dana-Farber Harvard Medical School in 2004, where she has been an active clinical translational research program in CLL, targeted therapeutics for CLL, as well as CLL genomics. She has been instrumental in the clinical development of ibrutinib and adalasib, leading to their regulatory approvals in CLL. Her genomics work has been instrumental in the description of the somatic mutation profile of CLL, she also has a long-standing research interest in the inherited predisposition to CLL. To date, she has published over 150 papers in the scientific literature, predominantly in the field of CLL. In 2014, she received 2 awards from Dana-Farber, the Clinical Innovation Award, as well as the George Carolus Award. She enjoys some aspects of chronic lymphocytic leukemia. Thank you. Over to you, Dr. Jennifer Brown.
Thank you so much for that lovely introduction. Let me just get my slides up here. I was going to focus really on therapy of CLL because that has certainly been where we've had most of our advances. Okay, there we go. Okay, so as everyone's aware, I think that the therapy has shifted substantially to targeted agents, either continuous therapy with BTK inhibitors or time-limited therapy with the BCL2 inhibitor venetoclax and anti-CD20 antibody. And as yet, we don't really know which of these regimens is preferred. And we don't even necessarily know what the preferred regimen in each category is, which I'll talk about. And there's a lot of interest in using minimal residual disease measurement to guide time-limited therapy in particular. And ultimately, the choice may be guided by what a preferred sequence is, which one works better after the other has failed. And that's also something that we understand very little about. Who should still receive chemoimmunotherapy, if anyone? And then where do we go with the advanced combinations, combining our targeted agents? As everyone knows, in the relapse setting, ibrutinib was the first-in-class BTK inhibitor approved based on the phase 2 trial, but this was the confirmatory analysis comparing ibrutinib to ofatumumab, where a median progression-free survival with ibrutinib was 44 months in heavily pretreated patients. And it was still worse for those with our highest risk disease, namely those with deletion 17p or p53 mutation, although not worse for those with deletion 11q. And now we're up to 7-year follow-up of the frontline original registration trial, RESONATE-2, in which ibrutinib was compared to chlorambucil. And at 7 years, the progression-free survival in this frontline elderly cohort is 61%. There has been about 41% discontinuation, substantially for adverse events, actually more than for progression. Most notable, I think, perhaps, are these data that were recently reported in the New England Journal of Medicine from NHLBI, a frontline study of ibrutinib, and again, those very high-risk patients with deletion 17p CLL, where at 6-year follow-up, the progression-free survival with single-agent ibrutinib is actually 61%. I think this was quite striking to many of us for these patients who used to have a median overall survival of 3 years prior to the availability of these agents. And these data have led many of us to consider continuous BTK the standard of care for these patients in most cases, because this does look better than our current targeted regimens in this subgroup. The Alliance trial told us that adding rituximab to ibrutinib does not add anything for progression-free survival in older patients. And the ECOG trial showed us that ibrutinib and rituximab improved progression-free survival compared to FCR in younger patients, particularly the unmutated patients, as you can see on the left, the higher risk patients. The mutated patients actually don't have a significant difference with ibrutinib rituximab compared to FCR. And I think this is important because of these data, where we know from 3 different trials that the mutated patients can have prolonged progression-free survival after FCR alone at 55% at 12-year follow-up. And many of these patients may in fact be cured, as we know that they have they have undetectable MRD at these time points. Our group actually sought to improve on these data by adding ibrutinib to FCR for this very young fit patients. And this was very straightforward design. They started ibrutinib 1 week prior to 6 cycles of ibrutinib with FCR, and then continued ibrutinib for consolidation for 2 more years, stopping when if undetectable MRD was achieved by that time point. And we saw continuous improvement in the rate of undetectable MRD in all subgroups, both mutated patients and unmutated IGVH patients. The best bone marrow undetectable rate by intention to treat was 84%, including a few patients we had enrolled with P53 dysfunction. If you exclude them and look only at the patients with wild type P53, but including both mutated and unmutated IGVH patients, the rate of undetectable MRD was actually 91%, which is the highest reported in a all-comer population with any regimen, actually. And we've just updated these data at IWCLL with a median follow-up of 40 months, and the progression-free survival is 97%, overall survival 99%. One patient who died actually had a sudden death event on ibrutinib consolidation. So we find this regimen to be quite promising in these very young fit patients as a time-limited regimen. And in fact, there are two other similar studies that have all reported these extremely high rates of undetectable MRD and 3-year progression-free survivals of 96+%. And so for these very young fit patients, I think this is a regimen that's important to consider. It adds essentially an additional line of therapy compared to sequential targeted therapies when we need to plan for decades of life for these patients. Particularly, we know that if we use single agent ibrutinib, if patients discontinue, at that point, there's continuous relapse. And it takes about 2 years for patients to progress, as shown here in data from the ECOG trial. And discontinuations are common for a variety of reasons, including arthralgias and infections, but what we most worry about are the cardiovascular toxicities. I think everyone's aware of the risk of atrial fibrillation with ibrutinib. And this details some work that we did with Javed Moslehi, a cardio-oncologist, identifying a high risk of a variety of other problems, including CNS hemorrhage, CNS ischemic events, ventricular arrhythmias, and sudden death, as well as hypertension. And we now also have a number of different studies looking at the impact on hypertension on our patients. And these are data from the Ohio State University showing that over 70% of patients develop new onset hypertension while on ibrutinib, and that this did lead to a higher risk of cardiac events. So what can we do about that? Well, we now have the next generation inhibitors shown here, acalabrutinib, much more specific for BTK, and zanubrutinib, somewhat more specific, but not quite as specific as acalabrutinib. And as you know, in the spring meetings, we heard a lot of data updating outcomes with acalabrutinib and zanubrutinib, which we'll go over briefly. These, of course, are all the covalent BTK inhibitors. So the ASCEND trial was the first randomized trial to report with acalabrutinib in the relapse setting, acalabrutinib versus investigator choice of idelalisib rituximab, or BR. And that has had a final analysis reported with about a 90% 1-year progression-free survival. But most notably here, you can see that in the acalabrutinib arms in purple, there's really no difference in outcome based on 17p53 mutation or unmutated IGVH. Now, the follow-up of this study was relatively limited, and that may be part of the reason that we don't see a difference here. But it is intriguing in these less heavily pretreated patients than the ones on the ibrutinib registration trial. And then in the frontline setting, we now have 4-year follow-up of the randomized trial comparing acalabrutinib to acalabrutinib obinutuzumab to obinutuzumab chlorambucil. And, I think what was most notable about these data are the intriguing difference between acalabrutinib obinutuzumab and acalabrutinib single agent, which was not a planned comparison, but the data have looked quite interesting since the first report when there was a 6% difference in progression-free survival. Now there's a 9% improvement in progression-free survival with the addition of obinutuzumab, as shown here. And it didn't seem to apply actually to the highest risk deletion 17p patients. You can see on the left that their outcomes were similar with or without obinutuzumab. But it does apply to the unmutated patients just as much as to the mutated IGVH patients, as shown on the right. And unsurprisingly, perhaps, it's associated with a higher CR rate that had increased over time, now 31% with obin versus 11% with acala alone, and a higher rate of undetectable MRD in the patients with CR, 38% with acala obin versus 10% with acala. I think it's probably that depth of response that's actually translating to the improved PFS. That there's increasing data that even with BTK inhibitors, achieving this increased depth of response early may be beneficial. The Elevate Relapse Refractory trial, of course, was reported at the spring meetings, ASCO and EHA. This is the head-to-head comparison of acalabrutinib to ibrutinib. This patient population was relapsed refractory, and they were required to have deletion 17p or deletion 11q. So it was a high risk, somewhat unique patient population. And the randomization was stratified by deletion 17p, ECOG, or the number of prior therapies. The statistical analysis was non-inferiority for PFS, and then a hierarchical evaluation of secondary endpoints that included atrial fibrillation rate, grade 3 infection, Richter's transformation, and overall survival. And as we'll see in the data, the non-inferiority for progression-free survival endpoint was met. The superiority for AFib flutter for acala versus ibrutinib was met. And then the other three were similar: infection, Richter's transformation, and overall survival. So again, just highlighting the patient population was 45% p53 aberrant and a median of 2 prior therapies. And all the patients without p53 had deletion 11q. So this is the PFS curve. Interestingly, it looks a little bit like acala is above ibrutinib early, and then there's a crossing of the curve. There's been much debate about what that crossing of the curve means, but we don't know. But overall, the hazard ratio is exactly 1 for this comparison. And these show the cumulative incidence over time of a variety of side effects. And you can see the AFib flutter rate on the left. The hazard ratio is about half for the use of acala compared to ibrutinib. For hypertension, the hazard ratio is 1/3. There's also lower rates of bleeding events, diarrhea, and arthralgia with acalabrutinib is shown here. I think this fairly convincingly shows that acalabrutinib is similarly efficacious to ibrutinib and better tolerated, which is consistent with, I think, most of the experiences of those of us who've used it extensively. Now, what about zanubrutinib? Zanubrutinib, as I noted, is not as much more specific for BTK as acala, but it has a different PK/PD profile, which was very specifically part of its design. The twice daily dosing results in sustained drug concentrations throughout the entire dosing interval. So for example, if you had resynthesis of BTK, zanubrutinib would be available to re-inhibit it during the dosing interval. This is not true of either ibrutinib or acalabrutinib, which have very brief PK exposure early in their dosing interval and then are below the threshold for inhibiting BTK after that. We don't know the importance of this PK difference in the setting of a covalent inhibition, which is permanent. Again, it depends really on the rate of resynthesis of BTK probably. But it is some rationale for difference in outcome with zanubrutinib versus ibrutinib. So the first trial to report was the single arm part of the frontline registration trial, which enrolled only deletion 17p patients. This was arm C of the Sequoia trial. And the 18-month progression-free survival for this approximately 109 patients treated with zanubrutinib for deletion 17p. So the largest prospective study in deletion 17p registrationally reported to date, the 18-month PFS was 91%. So really looked quite good. And I would note, we are actually going to hear the remaining data from Sequoia at ASH later this fall. But we heard Alpine in the spring at EHA. This was the randomized comparison of zanubrutinib versus ibrutinib in relapsed refractory CLL patients with at least 1 prior treatment. So note this is a very different patient population than in the Elevate relapsed refractory trial. These were just all comers, relapsed refractory with at least 1 prior treatment. And they were stratified by age, geography, disease that was or was not refractory, and deletion 17p or p53 mutation status. So the primary endpoint of this study was also quite different. It was overall response rate defined as partial and complete responses. And so that was significantly different at 78% for ibrutinib versus 62.5%, 78% for zanubrutinib versus 62.5% for ibrutinib. So, people are always concerned partial response with lymphocytosis is still a meaningful response. So if we look at that, there's still a difference, 88% for Zanu versus 81 for ibrutinib, but it's not quite as large as if we just look at partial and complete responses. The other notable point was that overall response was quite different for deletion 17p at 83% versus 54% with ibrutinib. And whether that'll translate down the line into a difference in progression-free survival is something that I think we'll all be looking for. At the moment, the follow-up is quite short, just about a median of 1 year for PFS, but there's actually a suggestion that zanubrutinib is better than ibrutinib, 10% better. What to make of this, I think, is unclear. it's very short follow-up. And if you look actually at Elevate relapse refractory at about a 1-year time point, there is actually a difference favoring Acala, and then that goes back down toward matching ibrutinib later. So I think we're waiting on longer follow-up, but it's fair to say that zanubrutinib was at least as good as ibrutinib, and maybe better. Atrial fibrillation was also substantially better at 2.5% versus 10% with ibrutinib. And other AEs of special interest, interestingly, there was no difference in hypertension. I think this also requires further follow-up, because in the Waldenstrom's randomized trial, we did see a difference in hypertension, but it was emergent after a year on therapy. So that may yet emerge. And there'd been concern about neutropenia with zanubrutinib. You can see it was a little bit higher, 28% versus 22% with ibrutinib, but generally find that to be quite manageable with a little growth factor, and often doesn't recur. So conclusions for this is that Acala and Zanu have both shown improved outcomes relative to ibrutinib in a randomized trial now, with at least equivalent efficacy and improved tolerability. Very hard to engage in any cross-trial comparisons between the acalabrutinib and zanubrutinib studies, given the very different patient populations, different study design, and different duration of follow-up. So my personal practice now, I believe that based on these data, Acala or Zanu are preferred where they're available, and that the difference is particularly important in older patients or those with a lot of comorbidities. Toxicity of ibrutinib is less in younger patients, which we saw clearly in the comparison of toxicity between the ECOG and Alliance trials. So it matters less for those patients, probably. Okay, so what about time-limited therapy? So of course, CLL14 has set the standard for this. This is the most recent update, where the 4-year progression-free survival following 1 year of venetoclax obinutuzumab therapy is 74%. And obviously this was much better than achieved with obinutuzumab chlorambucil. This again is an elderly patient population with comorbidities. Now, if we look at the P53 status, I alluded to this earlier. So P53 mutation did remain an adverse prognostic factor in the setting of this time-limited 1-year therapy, and the median duration of PFS for P53 aberrant patients has now been reached at about 4 years, which is still not bad, but it doesn't look quite as good as the single agent BTK inhibitor. The issue with all these studies, though, is we have such limited data on patients with 17p. We really need dedicated studies focused specifically on that population to better understand how to manage them. And I think there's still a lot of interest in time-limited therapy for them, but it tends to be more the multi-drug combinations and often MRD guided rather than fixed duration. And then IGVH status is also a prognostic factor in the setting, similar to what we've seen with time-limited chemoimmunotherapy. You can see that the ven-obin IGHV mutated patients are staying quite high there on the curve, whereas the unmutated patients are starting to show some continuous relapse as we get out to beyond 4 years. The median PFS in the unmutated patients is expected about 5 years. Now, we know that undetectable MRD in this study strongly predicted outcome. Undetectable MRD was detected in 75% of patients in peripheral blood and 57% in bone marrow on the ven-obin arm. By NGS, very similar, 74% at end of treatment in ven-obin. But what happens later? So here you can see in this graph the rate of undetectable MRD in green, ranging from below 10 to the -4 to below 10 to the -6. And so you do see over time that there is some recrudescence of detectable MRD, at least fewer patients who are undetectable. And again, off therapy. The risk of this was higher with high-risk features, was associated with higher clonal growth rates, which were estimated based on the data from the NGS assay. And in approximately 20% of the ven-obin patients, no clonal growth was measurable during the observation, indicating that they were in the very deepest remissions. And so again, raising the possibility that perhaps in these patients who probably were mostly mutated IGVH patients, there may be very long-term remissions like we've seen with chemoimmunotherapy, but we don't have that data yet. Now, about a third of patients continued to deepen their MRD response during the second 6 months of therapy on venetoclax monotherapy after stopping obinutuzumab. But if we look at the patients at end of treatment who are MRD positive, which were very few, only 20 patients, about half of them were having increase in their clone, which would suggest that giving more venetoclax wouldn't help. And the other half were having improvement or decrease in their clone. So in that case, giving more venetoclax might help them to achieve undetectable MRD eventually. So providing some rationale, again, for some level of MRD guidance in the duration of therapy. And this shows for those patients who did convert their MRD, what the median time to that conversion was. And it was about 21 months with venetoclax and obinutuzumab, which we'll see is very similar to the Murano study in the relapse setting. So what about the relapse setting? So this study is the phase 1 study of venetoclax rituximab, and really gave rise to the idea that stopping therapy, time-limited therapy, might work quite well in the setting of the deep remissions achieved with venetoclax and anti-CD20 antibody. Median of 2 prior regimens. The CR rate was 51%, bone marrow undetectable MRD rate was 61%. And at 5 years on study, the progression-free survival is 61%. But most notably, those patients with undetectable MRD had the option to stop therapy and be observed. And many of them remain in ongoing remission. Several have recurred, but most were able to be retreated and respond again to venetoclax. Again, providing the rationale that led to CLL14 and particularly to Murano, the randomized trial comparing venetoclax rituximab to bendamustine rituximab in the relapse setting, essentially patients with 1 prior chemoimmunotherapy. So this study is now reported a median progression-free survival with venetoclax rituximab in this setting of 54 months, so about 4.5 years. There was also an improvement in overall survival. This study did enroll patients with 17p, about 30% of the patients had 17p, so that does affect particularly the curves for the chemoimmunotherapy. Undetectable MRD, again, strongly predictive of improved progression-free survival after treatment, as shown on the left. The green curve are undetectable MRD, the red curve are high-level MRD. Now, if we look at the patients who were undetectable for MRD at end of treatment who converted, you can see that it was about 19 months from end of treatment to MRD conversion versus 21 months with Ven/Oven. It's very similar. And then, but then interestingly, similar to what we saw, say, in the ECOG study, the time from MRD conversion to progressive disease is about 2 years. This seems to be a reproducible number. This was also seen after FCR in the older studies that, again, MRD conversion to progressive disease is about 2 years. So that means even these patients who converted their MRD relatively early still had about 4 years before they had progressive disease from their end of treatment time point. So again, poor prognostic factors, unsurprisingly, included deletion 17p, genomic complexity of more than 3 or more abnormalities, and unmutated IGVH. These were all associated with higher growth rates, faster MRD doubling. And again, very similar to what we've seen with CLL14. And unsurprising in the setting of the fact that you stop therapy, so you're not providing any maintenance therapy to restrain the growth of the clone. So how do we choose between BTK inhibitor and Ven/CD20 as our first novel agent? Well, favoring BTK is the longer follow-up data, although this only applies to ibrutinib. Follow-up for Acala and Zanu is pretty similar to follow-up with the venetoclax trials, and those are all getting toward 4 and 5 years now. The use of next-generation BTK inhibitor improves the toxicity profile. The prospective data with venetoclax after BTK inhibitor are better than for the reverse. We'll just take a quick look at some of those data right after this. And there's obviously intense early monitoring with Ven, whereas BTKI is very easy to start comparing. Favoring Ven/R is the high CR and undetectable MRD. Overall, there are fewer long-term side effects. Patients are on therapy for a short time and then they stop compared to continuous therapy. This also may help avoid selection pressure for resistance. I find that patients really do prefer time-limited therapy if they can do it. And it also results in less cost. And then there's the potential for retreatment. So instead of, quote, using up a therapy, which patients often worry about, they'll be able to use that therapy again. All right, so what about sequencing? What little we know about it? This is the one prospective trial in that setting in which venetoclax was given to patients progressing after ibrutinib. Enrolled about 91 patients with 4 prior therapies, very heavily pretreated, half with 17p. But what's most notable, I think, is the CR rate is very low and the rate of undetectable MRD is very low compared to what we see in patients who've not progressed on ibrutinib. Furthermore, the median PFS is also low, about 2 years. after progressing on ibrutinib. So there is less benefit to venetoclax in this setting compared to when venetoclax is used as a first novel agent. I think this is likely to be true in reverse too, but the follow-up is shorter. Predictors of relatively poorer response to venetoclax include, like I said, refractory to BCR inhibitor, bulky lymphadenopathy, deletion 17p, and in the relapse setting, Notch1 mutation has been shown to be an adverse prognostic factor. That's not been the case so far in CLL14. Favorable response, deeper response is predicted by early complete remission or undetectable MRD. Now, what about retreatment? So we have some updates from Murano with retreatment, where we know that deep MRD responses are possible. So in the top line here, you can see the patients who were retreated in terms of whether they had undetectable MRD after their first round of treatment. So you can see, and then below that are the patients, what they achieved after retreatment. So you can see there are a large chunk of patients in the middle who are undetectable MRD after their first round of venetoclax rituximab, who were detectable after their second round. So the message, I think, overall is unsurprisingly that at least for these early relapsing patients who, as we'll see, had high-risk features, the likelihood of achieving undetectable MRD again is lower than it was the first time, but still definitely present, as you can see here. And again, so these patients had unfavorable genetic features. They were almost all unmutated. Many of them had complex karyotype, and 56% actually had P53 aberrancy. So as we see patients who are relapsing later, it's likely that the likelihood of achieving undetectable MRD again will be better. Now, in this cohort, there was some clonal evolution described in patients relapsing and being retreated. There were many clones of 17p, for example, that grew, which is shown in the right panel. So 30% of the clones were more than 20% of the cell population at baseline 1, but then at retreatment was 77% of the clones. Again, not surprising, I think, and not dissimilar from what we've seen with other time-limited therapies. Also, increase in genomic copy number from a median of 2.5 to 4 at second round of treatment post-Murano. And then, most importantly, those patients with increased 17p clone size and genomic complexity had a lower likelihood of achieving undetectable MRD. Again, not surprising, but reported here from the Murano data for the first time in the EHA meeting. Now, what about the reverse? So we have mostly anecdotal data for BTK inhibitor therapy after patients resistant to venetoclax. That being said, it looks quite good. These are the data with the longest follow-up, about 3-year follow-up from the Australian group, where they did see a median PFS of approaching 3 years in extremely heavily pretreated patients, similar to the phase 1 study originally with ibrutinib. And so it really looks about the same as the phase 1 study, despite the prior venetoclax. But predictors of longer response to BTK included the depth of remission to venetoclax, as well as durability of venetoclax response of more than 2 years. Again, as expected, as we understand from all our therapies for CLL. So what about combining BTK and BCL2, combining more active agents? So the idea is the deeper we can drive down detectable MRD, the longer or later the relapse. And if we drive it down far enough to the point where we can't detect it at all, maybe we can get to cure. And so the sensitivities for flow cytometry can get to maybe 10 to the -5th, NGS can get to 10 to the -6th fairly routinely. But below 10 to the -6, we haven't routinely been able to measure in CLL. But nonetheless, driving down further, we may expect to correlate with cure. So studies looking at this. So the phase 2 Clarity study from the UK combined ibrutinib with venetoclax, 54 relapsed patients. This had an interesting MRD endpoint in terms of MRD eradication at 1 year was the primary endpoint, but the duration of therapy was dependent on the timing of MRD eradication, with approximately double the time it took to get to undetectable MRD, given again as consolidation. And they ultimately added an extra year to the study to see if they could enhance undetectable MRD. So here you can see just serially over time in green, in blood on the left, bone marrow on the right, the improving rates of MRD as we get out to 2 years of therapy. And then when they did extend to that 3rd year, you can see actually in the highlighted in bold that there wasn't a lot of improvement, that there was continued improvement from 1 to 2 years, but as you get to 3 years, look like there might be a plateauing in the rate of undetectable MRD. The other very interesting data from this study related to the rate of depletion of disease in the first 2 months on therapy. So if they had greater than a 2-log depletion, as shown in purple, these patients were the ones who were able to stop therapy with sustained undetectable MRD and a low likelihood of recurrence. The less than 2-log depletion, as shown in yellow, only 20% of these people achieve sustained undetectable MRD. And so the early depth of response may actually predict the likelihood of long-term undetectable MRD. And the PFS in this relapse study is actually 96% at 3 years, which is really quite remarkable. Although only about half the patients have stopped treatment with undetectable MRD. But so far, the ones who have stopped treatment have had mostly stable MRD levels. Now, what about in the frontline setting? These are the MD Anderson data recently updated and published in JAMA Oncology. 69% rate of undetectable MRD in high-risk CLL patients after 18 months of venetoclax ibrutinib in the frontline setting. And this led, of course, to the Captivate study, which is two completely different studies, actually. This is the study design for the MRD-guided one. So both components of the study had 420 milligrams of ibrutinib for 3 months lead-in, and then 1 year of combination ibrutinib venetoclax. In this part, patients were then assessed for confirmed undetectable MRD, which required at least 3 measurements of undetectable MRD, one of which was in bone marrow. So the rate of that was 57%, and those patients were randomized to either continue ibrutinib or stop ibrutinib. The patients in whom undetectable MRD was not confirmed, which included those who may have had measurements of undetectable MRD but didn't have 3, were randomized between ibrutinib or ibrutinib venetoclax. So median follow-up is 31 months for all groups. A best response of undetectable MRD was in the 72 to 75% range. And the 30-month PFS for all groups was over 95%. But remember, almost all these patients are on treatment. Only about a third of them stopped. Now this looks at the third who stopped, essentially. The confirmed undetectable MRD patients, which were 57%, half stopped on placebo and half continued ibrutinib. And at 1 year, their disease-free survival was similar to those on ibrutinib. Disease-free survival rate here includes recurrence of MRD. So of course, I think the problem with this is 1 year is not long enough for us to really interpret this, and we'll need a lot longer follow-up. I also think it would be very useful if more patients came off therapy. The goal of this combination therapy is really to stop therapy. And so that's why we have the fixed duration cohort. That was 159 patients who did the 15 months and all stopped at the end of therapy. Primary endpoint, complete response rate. So here you can see now, these were very young patients, median age of 60. Only a quarter had high-risk disease. 56% had unmutated IGVH, but high-risk cytogenetics were unusual, 17% with deletion 17p, and disease burden was low. So you need to remember that these were very healthy patients with not a large disease burden. The overall response rate, very high 90s, CR rate 56%, also true in the 17p population. Undetectable MRD rates in blood were 77%, and in bone marrow were 60-ish%. And were similar in 17p, although bone marrow was maybe lower in 17p at 41%. So I think this is rather interesting because to me, this doesn't look a lot different than venetoclax obinutuzumab for 1 year in patients with a higher disease burden, older, and with comorbidities, where we had 75% rate of undetectable MRD in blood and 57% in marrow. PFS looks great, of course, 2-year PFS of 95%. And of course, we're waiting for longer follow-up. So again, the question is adding ibrutinib improving that much on outcome compared to venetoclax with obinutuzumab? And we'll come back to that question a little bit later. First, let's look at GLOW. So this is a randomized registration trial for this ibrutinib venetoclax regimen of 3-month lead-in of ibrutinib, then ibrutinib venetoclax for 12 cycles. This is compared to obinutuzumab chlorambucil in older patients with comorbidities. Deletion 17p patients were excluded because of the randomization to obinutuzumab chlorambucil. So here, very different. Median age is 71. Median Sears score was 8 to 9. Some reduced creatinine clearance, double the number of patients with Rye stage 3-4 disease, more patients with bulky disease, although still not that many. And a rate of unmutated IGVH is about the same. So here, overall response rates are about 85% compared to 95% in the other population. CR rate is 39% with IV, again, compared to 55, 56%. And if we look at rates of undetectable MRD on the right, you can see they're 52 to 55%. So actually, if anything, a little bit lower than a very similar patient population with venetoclax and inotuzumab. This is the progression-free survival. You can see as soon as chlorambucil inotuzumab is stopped, there's a rapid drop-off, but with IV, we're still seeing nice sustained responses for many more months. So the adverse event profile here is non-trivial. 35% of patients had grade 3-4 neutropenia, 17% rate of grade 3-4 infection, which is quite similar to chemoimmunotherapy, and also ibrutinib. 10% diarrhea, 7% AFib. So the toxicity in the older patient population here is greater than we see with the Captivate younger patient population, as expected with ibrutinib. So that was the 2-drug combination. As you might expect, we have 3 drug combinations. This is the Ohio State data for ibrutinib, venetoclax, and inotuzumab. 3-year follow-up, progression-free survivals are 95%. The rate of undetectable MRD is perhaps not as high as we might expect it, but in bone marrow, it was 56% in the treatment-naive cohort. Our group has done acalabrutinib with venetoclax and inotuzumab, which recently published in Lancet Oncology. At the cycle 16 primary endpoint evaluation, bone marrow undetectable MRD was 76%, blood was 84%. Those patients who reached CR with undetectable MRD at cycle 16 could stop. Patients otherwise continue to cycle 24. And then anyone with undetectable MRD can stop. And then that has led to a phase 3 registration trial, which is ongoing, comparing acalabrutinib venetoclax for 14 months to acalabrutinib venetoclax and inotuzumab for 14 months to chemoimmunotherapy. This is for treatment-naive subjects with active CLL of any age, stratified by age, IGVH, Rye stage, and geography. There'll be a couple of years till we get the readout of this study. And then BOVEN is the zanubrutinib venetoclax and inotuzumab combination led by Jake Sumray and the Memorial Group. 89% of patients achieved undetectable MRD and stopped at a median of 10 months. And follow-up is still very short, but it'll be interesting to see how they do now. So where does it leave us? So are these 2 and 3 drug targeted combinations better than venetoclax anti-CD20? In the unholy cross-trial comparisons that I mentioned as I was presenting them, it's not so clear that higher rates of undetectable MRD are necessarily being achieved, particularly with the 2-drug combinations. We don't have any large multi-center 3-drug combo studies yet, so that's still pending. And the big question is, does the CD20 add to the BTK BCL2? And then how do time-limited regimens compare to continuous regimens in terms of treatment goals, efficacy, toxicity, cost, resistance? Some key issues to consider when we think about comparing these head-to-head are that you can repeat a time-limited regimen until it no longer works. Continuous regimens have increased toxicity and cost. And then the likelihood and type of resistance may differ, and we don't understand that yet, and we still need to collect that data. I also think the answers may differ based on disease prognostic features, as we saw with FCR. Mutated IGHV patients can be cured by FCR, whereas with unmutated patients, there's continuous relapse. And that may be somewhat similar with time-limited regimens in particular with targeted agents. So there are some studies addressing these questions that we don't have data from yet. CLL17 of the German CLL study group comparing fixed duration with continuous therapy, ibrutinib monotherapy to venetoclax and inotuzumab a la CLL14 to ibrutinib venetoclax. And the stratification here is by fitness, by deletion 17p and IGVH. I think it's very important to note that many of our earlier registration trials were not stratified by IGVH, and that has complicated the analysis of the data. And so fortunately, many of these newer studies are stratifying by both 17p P53 status and IGVH, which is going to be very important. Then we also have the MAGIC study, which is being co-led by my colleague Matt Davids, Jeff Sharman, and Anthony Mato. This is MRD-guided venetoclax and acalabrutinib versus MRD-guided venetoclax and obinutuzumab. Basically, one opportunity to stop for undetectable MRD at about 14 months, otherwise continuing to 24 months. This will use a second-generation BTK inhibitor in the combination, which is useful. And then it's also directly comparing time-limited regimens, but doesn't have a continuous therapy arm. I wanted to mention the IMPROVE study. This is a somewhat different approach, which I think is also something that could be quite useful in terms of maximizing our benefit to patients for the different therapies we do. So this was led by the Italian group Lydia Scarfo. So relapsed refractory patients with CLL naive to BTK or BCL2 inhibitors were started on venetoclax for a year. And then those with undetectable MRD could stop. For those who still had detectable MRD, added ibrutinib for potentially a year. And notably, so most of the patients, 80+% of the patients who added ibrutinib actually achieved undetectable MRD after 12 cycles of the venetoclax-ibrutinib combination. I think this is quite interesting because normally we don't think of ibrutinib as a drug that will clear MRD, but clearly the synergy potentially between venetoclax and ibrutinib is achieving that. And then just a few patients still MRD positive continued ibrutinib monotherapy. So in a way, this allows patients who achieve undetectable MRD with venetoclax monotherapy or say venetoclax CD20 to stop when they're undetectable, but then provides additional therapy for those who need it to achieve undetectable MRD. And I think this is a place where there's room for a lot of additional trials going forward using other mechanisms other than ibrutinib to perhaps clear the MRD after initial venetoclax-based therapy. So in summary of this part, patients with disease progression on BTK inhibitor or continuous venetoclax are best treated with the other agent. Prospective data are limited, but certainly support venetoclax after prior BTKI. Patients who stop a BTKI for an AE, such as ibrutinib, can receive a more specific BTKI or venetoclax. You can retreat venetoclax CD20 patients. The longer their prior duration of remission, the better. At least 2 years is probably preferred. And then disease progression on both of these drugs now represents a major new unmet need with no clear standard of care. We have PI3 kinase inhibitors, but we don't have any data in this patient population, and anecdotal experience suggests a limited durability of response. I'm just going to briefly show you some data with non-covalent BTK inhibitors, as well as CAR T. But I think this problem of this major new unmet need suggests that the idea of using time-limited therapy or clinical trials before using both of our two available targeted agents, if you have access to these other options, is a good idea. So the non-covalent BTKIs are listed here at the bottom. They were designed to target the mechanism of resistance to the covalent inhibitors, which is of course mutation of the cysteine 481 residue to serine, which abrogates covalent binding. Vecabrutinib didn't have a lot of activity, has been discontinued. ARCUL 531 has had good activity and is in an additional phase 2 escalation study. Luxeptinib is in ongoing phase 1, still too early to know. Pirtobrutinib looks very promising, and I'm going to show you some of that data. So this is a very, very specific drug for BTK as shown here, a non-covalent inhibitor, so it has similar efficacy against C481S as against wild-type BTK. And now has actually treated 350 odd patients, 170 with CLL, SLL. And these patients had a median of 3 prior therapies. 86% had prior BTK, a third had prior BCL2, and a fifth had prior PI3 kinase. 2/3 discontinued their BTK for progressive disease, and a third for toxicity. At the moment, the evaluation for BTK mutation is not complete in the patient population, and so far, not as many patients have had BTK mutations as we might have expected based on prior data, but I think we'll look for an update of that soon. And about a third of the patients in the study had P53 mutation. Very notable about pirtobrutinib is its safety profile. You can see here that in this entire patient population of 323 patients last reported, there are almost no grade 3 or 4 adverse events, no DLTs, and the MTD was not reached. So fairly remarkable. Efficacy is also quite good, regardless of prior BTK, reason for BTK discontinuation, or prior BCL2 inhibitor, as shown here. The efficacy in CLL, the overall response rate in all evaluable patients was 63%, but as we expect with an effective BTK inhibitor, that improved over time, largely due to a decrease in partial response with lymphocytosis. So patients who've been on study more than 10 months were up to 86% for their overall response. Follow-up is still short, though. You can see here on the left, about half the patients are out more than 6 months, but extremely encouraging in a highly refractory patient population. And then what about CAR T? So Lysocell has presented some of the most encouraging data. This is a defined composition CAR T product with CD4 and CD8 cells mixed in a defined composition. We have 2 different cohorts. These are the data from the relapsed refractory patients where the median PFS is about 18 months. I draw your attention particularly to the lower section of the swimmer plot. These are patients who had progressed on both BTK and venetoclax. And so in this group, you'll see that there are quite a few progressions, and there have been 4 out of 6 progression events due to Richter's transformation. So I think that this might suggest that treating less refractory patients with CAR T, as shown in the top group, where we see many more patients are still on study in response, and may be more effective. Alternatively, there's the possibility of adding a BTK inhibitor. Now, the rationale for adding a BTK inhibitor has been several-fold, that it may improve the underlying T cell function, the underlying T cell defect of CLL patients, so that their T cells will work better as CAR T cells, that it may help with the expansion in vivo, and that it may decrease the rates of cytokine release. And so far, we have phase 1 data of Lysocell with ibrutinib, and the CR rates look pretty good at 63%. And you can see the rate of undetectable MRD on the right in marrow is 79%. So quite encouraging, but only very few patients treated, on the order of about 20 or so. And this shows that they're ongoing, fewer relapses than in the other cohort, but a shorter follow-up too. So the future, I think therapy will be selected based on a combination of patient features or desires and disease biology. P53 and IGHV mutation status seem to be maintaining their utmost importance as prognostic factors and predictive factors in this disease. And then there really is a difference between the young fit patient who's working and the older patient who may not want to come into clinic as much, has a lot more comorbidities in terms of therapy selection, even with our targeted agents. I think MRD-guided time-limited combination therapies will become more common, or common for younger patients and for high-risk patients. The older patients, I find, are much happier with a single-agent continuous therapy if it's not a lot of work coming into clinic. And then escalation of therapy, doublets, triplets, and/or consolidation strategies will be developed for patients with persistent MRD positivity. And this could include cellular therapy like CAR T. And I think a lot of us are pretty interested in the potential for bispecifics in this space as well. Well, thank you very much for your attention. Happy to.
Thank you so much, Dr. Jennifer. That was fantastic. You took us right up to what is happening and what's going to happen in future. And it's amazing the amount of data that has been collected in this particular field. The future looks very, very bright. All this work is going to help the patients. So we have our Indian colleagues here. They would like to ask you some questions about their difficulties. Start with Dr. Deepak Charles.
Thank you, ma'am, for that excellent overview of CLL. My question was with regard to deletion 11q CLL in a 65-year-old fit male patient. What would be a line of therapy, whether it be like BTK inhibitors, or would you consider alkylating agent?
So, I think that's interesting. We've always considered deletion 11q to be higher risk disease, and in the relapse refractory study from ibrutinib, it did actually show an earlier relapse. Then there was a suggestion from a combined analysis of, and as well as from RESONATE-2, that actually BTK inhibitors were particularly effective in 11q. It looks like with the longer follow-up curves, I didn't put it in, but with the most recent update, they've kind of come back to being similar to all other patients, so not worse, but not necessarily better. You know, my view of 11q clinically is that there's really a wide variation in it. There's some patients who look like they have disease that's almost as bad as P53 disease, huge adenopathy, bad cytopenias. And those patients I kind of think of as like P53 patients, which would make me favor more a BTK type approach. I also think if they have aggressive disease like that, they may need the sustained therapy, similar to the P53 patients. But then there's some who, you know, they have mostly circulating disease, they don't have big adenopathy, they look sort of like your average unmutated IgV patient. And for those, I would feel okay. And, you know, maybe it took them 6 years time to therapy, so relatively slow moving disease as well. I feel comfortable doing an open or time limited therapy if that's what the patient wants. I wish, and this has been sort of an ongoing interest of mine, that we knew how biologically to find the difference in those patients. And we still don't, I don't think. There was a little bit of data suggesting that mutation of the other ATM allele was associated with the more aggressive pattern of disease, but it hasn't really been necessarily convincing. So, you know, I still sort of add that clinical judgment to the overall kind of disease features.
Thank you, Dr. Deepak. Dr. Afak?
Thank you, sir. Thank you, ma'am, for an excellent update on CLL. My question is regarding MRD. MRD is still used in the context of a clinical trial. We don't use it in routine daily clinical practice. And my question is, can we use MRD to decide the duration of treatment? For example, you have a CLL patient who is on continuous ibrutinib therapy, and at the end of 3 years, he's MRD negative, 4 years he's MRD negative, and 5 years he's MRD negative. Can we think of stopping the drug here? Or vice versa, if there's a patient who has received fixed duration obinutuzumab and venetoclax for say 1 year, and at the end of 1 year his MRD is positive, do you want to continue here the treatment? What is your take on that, using MRD?
Yeah, so I'm somewhat skeptical of using MRD with single agent ibrutinib. I haven't actually seen much of any undetectable MRD in patients on single agent ibrutinib. It's a little bit more complicated, say if the patient got obinutuzumab or got something else together with their ibrutinib. Some of those patients do get undetectable MRD, but we don't have data to stop. So, you know, I guess the way I think about it is if the patient has no side effects from the drug, doing fine on it, my inclination with the BTK inhibitors is to keep them on it because that's where we have the data. You know, if they're having a lot of side effects, they're not doing that great, and they have a deep remission, that would kind of, you know, affect my view of, is it reasonable to stop or, you know, be more inclined to stop given the side effects. But I wouldn't just decide to stop because we don't have data on that. Now, with the venetoclax obinutuzumab or the time-limited regimen, you know, I think the place where this is, I'm mostly following the design that you just stop at a year and see what happens. Most of my patients who still have detectable MRD, it's low. The patients where I think I and others are hesitant to stop if they're still detectable are the 17p patients. You know, I think those patients I seriously would consider continuing and maybe getting some additional values. You know, if they're continuing to lower their MRD, that's encouraging that at least the venetoclax is working. But in Murano, for example, we saw that many of the 17p patients actually already had rising MRD at the end of treatment. So those patients are probably going to need another treatment soon anyway. We don't actually know whether it matters in that setting if you stop them or you continue them. Like, are they still partially sensitive to venetoclax? We don't know. I probably would leave them on until you gave them, or until you knew what you were going to do with them next. Just, you don't want to, we don't really see explosive disease stopping venetoclax like we did with BTKs, but it's still a bit of a worry in those 17p. In the non-17p patients, like I said, even if they have very low level detectable MRD, at the moment, I'm still sort of stopping and seeing what happens outside the context of clinical trials.
Thank you.
Dr. Shweta?
Ma'am, I had a couple of questions. What will be our choice of therapy when we have 17p deletion?
Right. So in the absence of a clinical trial, I generally would go with the continuous BTK inhibitor. I have to say, those are patients where I do consider adding an antibody for better cytoreduction and more rapid cytoreduction, despite the fact that in Elevate TN, we're not seeing an obvious benefit of the open. I felt like sometimes you can get a sluggish response with the single agent BTK in those high risk patients. And, you know, to get a more rapid response, I do sometimes add not Rituxan. I mean, not Rituxan with ibrutinib. We know that that doesn't do anything, I think, from multiple trials. But if you have access to Obin, I do sometimes use Obin.
Ma'am, you think we are ready to use ibrutinib plus venetoclax in real world outside clinical practice?
So I'm not really inclined to be honest. I don't think the data make, so there's the risk that you use both drugs up, so to speak, and the data don't really look better than using venetoclax or obinutuzumab if you want a time-limited regimen. I think some of the argument has been that it's all pills, right? So it's 2 drugs, it's all pills. And that may be true, but you still have to do your venetoclax escalation where the patients have to come in for 5 weeks anyway. So it's not like it's completely easy. So, I mean, we'll see. I think most of the experts in the US, when I'm on advisory boards and things, most of us are a little bit skeptical. I would say that the 17p patients, though, I would consider doing that for them, for sure.
What are the side effect, adverse effect profile that we're looking at with this combination?
Side effects of what? I'm sorry?
Of the combination, venetoclax and ibrutinib.
Yeah, you know, they're the side effects of each one individually, but they're definitely enhanced. So there's definitely more neutropenia. There's definitely a lot more GI stuff, you know, nausea, reflux, diarrhea. You know, you can usually manage that, but you definitely see it. The infection rate is not, at least in the older patients in the study, is higher than with the individual drugs as well. I mean, it's manageable. I think actually with the next generation BTKs, it's going to be quite a bit better. Like we've done a bit of work with the acalabrutinib venetoclax combinations, and it's still harder than the individual drugs, but I think not quite as bad as ibrutinib. For example, you get a lot less AFib, right? Because ibrutinib venetoclax, you still have the AFib, just like you would with ibrutinib, and hypertension.
Thank you, ma'am. Thank you so much. A very wonderful lecture, ma'am.
Thank you.
Akanksha.
Yeah, thank you, ma'am, for that comprehensive talk. So I had a question regarding the use of ibrutinib in a patient who has got a history of atrial fibrillation. And if we do not have the option of acalabrutinib or zanubrutinib, how would you approach this patient? As well as what about the anticoagulation in such patients?
Yeah, so I've gotten fairly comfortable with resuming or using ibrutinib. If patient has pre-existing AFib that's well controlled, usually they're okay. You do get occasional patients who it gets a lot worse and you can't control it, and then you're just going to be stuck. But most of the patients with the pre-existing well-controlled AFib, you can use ibrutinib. Or if they develop AFib, but you can control it and they're not asymptomatic, you can use ibrutinib. I've gotten pretty comfortable with anticoagulation, although I mostly use apixaban, the direct oral anticoagulants. I think low molecular weight heparins are also fine. They seem to have not a high rate of hemorrhage. I would not use warfarin.
And one more question.
Yeah, go ahead.
Yeah, and one more question was regarding the MRD. Is it required to be done both on the peripheral blood and the bone marrow, or just one is enough? Like
no,
in the studies you're showing. Yeah.
Yeah, so the studies, we all do bone marrow because, you know, we're trying to kind of aim for cure. And so you want to look for total eradication of disease. Bone marrow, it tends to be about a log more sensitive than blood. But the outcome data that we have from the trials are all reported in terms of blood, right? So the CLL14 outcome data are in terms of blood. So I think you're fine just doing blood. Yeah.
Okay. Thank you so much.
Dr. Aishwarya.
Thank you, ma'am, for the extremely updated talk. My question is, like, in India, still now everywhere we are talking about the BTK inhibitors, there are still some patients who can't afford them. So in a young fit patient with deletion 17p or TP53 positive, where only chemoimmunotherapy is an option, so can we plan them for bone marrow transplant once we achieve cytoreduction or like a CR sort of status?
Yeah, I mean, I think that's certainly what we did before we had these drugs. You know, you can actually get responses to FCR in a lot of 17p patients, especially if they have mostly blood and marrow disease. And then I would probably plan to try and take transplant if you're young and fit, because you don't have a lot after that. You have like high dose steroids. I don't know if you can get alemtuzumab, but that would be kind of it if they can't afford targeted agents. So yeah, that's what I would do.
Thank you. Dr. Aniket Mohite.
Thank you, sir. Thank you, ma'am, for this detailed talk. I have a couple of clinical scenarios. One patient, 73-year-old gentleman who has been diagnosed CLL since last 17, 18 years. He had now progressed on ibrutinib, developed some toxicity with adalimumab. He is planned for RIC. He and has completed RIC, relapsed after the RIC transplant. So what will be your further line of therapy for this patient?
So you said progressed on ibrutinib and now has had a transplant?
He has progressed on ibrutinib and adalimumab. He received a brief venetoclax course before as like a bridge for transplant. But
and now progressed on after transplant?
After transplant.
Okay. I have actually had a couple people like that who had brief courses of venetoclax prior to transplant, where I've been able to use venetoclax afterwards and actually had much better responses. One patient who had sort of barely had a partial response beforehand actually achieved CR for multiple years. It seemed that it actually was activating the graft based on some of our analyses of bone marrow. So I would probably try that. The other thing is, I don't know if you have access to mutation analysis, but if you can determine if the clone has evidence of a BTK mutation, for example, then you certainly couldn't use a covalent BTK. But you could, I don't know if you can access combinations. That would be the other thing. Like if you try the venetoclax, you don't really get anywhere, then try to add ibrutinib to it.
I mean, what would be the timeline of his therapy? Like, would we continue him for a long term, or would be this?
So is the person not relapsed after their transplant, or they did relapse?
He has relapsed after a retransplant.
I would continue it. So that kind of person, you can't stop the venetoclax. I mean, I would just continue it indefinitely, as long as it's working. Yeah. The other thing is, if you have antibodies, you could add an antibody. It does seem to enhance response in these refractory kind of situations with venetoclax, I think.
Okay. Another is a 63-year-old gentleman. He is kind of refractory to the therapy as well and has a single kidney as his congenital abnormality. So he's not progressed on ibrutinib. I never tried him on acal or adalimumab. So in such patient, would you go ahead with some other modality of therapy like venetoclax plus obinutuzumab, or would RIC or CAR-T would be the preferred therapy in this scenario? Like, how do we go ahead if he has progressed on ibrutinib with a single kidney?
Yeah, so I mean, venetoclax does have a lot of activity. Your comfort level with that, I think, is going to depend on what his actual renal function clearance is and the bulk of disease. If he has really bulky disease and poor clearance from a single kidney, it might make me a little nervous. You could try some type of cytoreduction. Historically, I've used a lot of high-dose methylpred to kind of get people's disease under control if they were exploding on a BTK inhibitor, and then kind of segue, and also antibody, and then segue into the venetoclax. So you could consider something like that, but you're just going to have to watch out a lot for tumor lysis if the person has very progressive disease on their BTK and the limited renal function. The other thing is you can use PI3 kinase inhibitors regardless of renal function. I've given them to people on dialysis, but the activity in patients whose disease has progressed on ibrutinib is not well established, whereas venetoclax definitely has activity. The high-dose methylpred definitely has activity. The regimens that have been studied with the 3 to 5 days of a gram per meter squared Q month, which they date back to before our targeted inhibitors. But they still can, I assume that's something you could do.
And then my last question, how do we dose adjust, like there's data of venetoclax with use of antifungals, like we see a lot of fungal infections or tuberculosis infections in India. So if we are using rifampicin, which is a drug inducer, or we are requiring them to start them on Vori or posaconazole as an antifungal therapy when they are aspergillus. So how do we dose adjust ibrutinib or acalabrutinib like what we do for venetoclax? There's a bit of literature of venetoclax.
Yeah, so ibrutinib, you definitely have to dose adjust down to 140 for Vori, or you're not really supposed to give it with POSA, but sometimes we do. Acala, so the Acala label says that you're okay with a moderate inhibitor, but I often dose reduce it anyway. And those are strong. Well, POSA at least is a strong inhibitor, so I would probably do the Acala half. And then, so for the venetoclax, if you have to do it, I try really hard not to have to do a venetoclax escalation with that, but I would start at 10 in the hospital if you had to. And then you only go to 200.
Okay.
Thank you, Dr. Dr. Sandeep.
It was a great lecture, Dr. Jennifer. This question came to me because 2 days back, I saw a new 43-year-old young CLL, and he was in stage 0 only. And he asked me a question. I told him that you need only observation. And he asked me, doctor, why don't you treat me? Because I have early disease. And you all say that early cancer and treat them and you will be cured. So now with availability of this 3-drug combination, anybody has done this trial on treating early CLL patients right now? We keep them under observation with this combination and give them 6 months, 9 months finite therapy, and maybe they are cured.
So no one has really done that. There's an intergroup study in the US that's starting for a year of venetoclax obinutuzumab for high-risk patients. I don't think we have any evidence that we're curing people with venetoclax obinutuzumab, though, especially not high-risk patients. The low-risk patients, our best data that we might cure them with FCR-based therapies, or FCR and ibrutinib. We don't really have that data for the triple drug combinations yet. I'm not aware that anyone has initiated a study, say, with an early triple drug combination. In Denmark, they're doing like 3 months of I think it's a Calaven. I'm not sure though. It could be a ibrutinib then. It's a BCL2 for like 3 months for patients who have high risk on their scale where they measure likelihood of infectious comorbidities as well as disease. We don't have any outcome data yet. We don't have any good data for early treatment where the outcome is an appropriate outcome endpoint. Overall survival is really the best endpoint. And this intergroup one that's starting with Ven Open is actually trying to look at overall survival. I'm not sure it's adequately powered, but at least trying. The other thing you could do is try to look at sort of time to therapy failure or time to next therapy, like second therapy. Most of the studies, the study with ibrutinib from the German CLL study group, it just looks at event-free survival where being treated as an event. And so that's like a tautology because you've treated one part of the group early versus the other. So I don't think we've really learned anything from those studies. So we need sort of another generation of studies to try and address this.
My just second last question is, what is the incidence of diarrhea or GI disturbances with venetoclax? I saw 3 patients having severe diarrhea with venetoclax, not with ibrutinib and then with venetoclax. So, do you have any such experience?
That's interesting. Maybe very few, maybe 1 or 2. So I actually see more upper GI problems with venetoclax, like nausea and reflux type things than I have diarrhea. But you do occasionally see diarrhea. 3 in a row, that sounds a bit disproportionate to what we've seen. But I mean, it's possible. You should check if they're on any other drugs that also cause diarrhea. I do think you get kind of synergy of these GI things.
It was only on venetoclax.
Okay. Oh, that was it. Okay. Yeah. It helps sometimes if you have them take it at night compared to the morning. Some of the GI side effects are less if they take it and go to bed. Also, make sure they take it with fatty food. That also helps the GI side effects.
Okay. Thank you very much. Thank you.
Dr. Bhavin.
So good evening, madam. It was an excellent presentation. And as there are a lot of combinations are available for treatment with CLL patient. Now, what are your treatment of choice if patients with without high-risk features, if a young fit patient presented with IGHV mutation or elderly patient with IGHV mutation and without IGHV mutation with no high-risk cytogenetic abnormality. So what are your preferred choice of treatment in this group of patients?
Yeah. So for the young, fit, mutated, IGBH mutated patients, I do actually offer them that sort of ibrutinib FC-based combination type therapy that I presented to you. And then also ven-oben. I mean, I offer them everything. I also offer them continuous BTK, but I favor something time limited. So, some of them really like the idea of the long-term FCR follow-up and the idea of cure, and they're up for that. But many of them don't want chemo at all these days. And so then, I favor the ven-oben, especially for the IGBH mutated patients. For the unmutated patients without high-risk genetics, it's kind of almost the same discussion, really, because I think they really prefer time-limited therapy. What we're going to have to see is in the progression-free survival curves over time, say with the ibrutinib venetoclax compared to ven-oben, do we find greater durability from the ibrutinib venetoclax versus the ven-oben, or even the triple drug combinations? We don't know that yet. I think when that the study that I mentioned, the AVO versus chemo, when that study reads out, I think that I might be more inclined to use the AV type regimens. But and not yet, really.
Okay, and in elderly patient?
Elderly. So, I find the elderly patients are much less likely to want to do the work to come in to get the oben, to get the venetoclax escalation. That a lot of them are much happier. They don't mind taking the pill every day. I use Acala currently as my sort of go-to BTK inhibitor. Xanu has not yet been approved for CLL in the US, but especially in the elderly patients, the toxicity profile is a lot better for Acala compared to ibrutinib. So, but again, I offer them, so I wouldn't offer them the FC-based combination, obviously, but I offer them, whatever trial we have, the ven-oben or the BTK. But I just find that the older patients are the older the patient, the more likely they like the BTK because they don't have to come to the hospital so much. They don't have to sit there all day. Whereas the younger patients like the idea of the time limit and they can get back on with their lives, even if it's a little bit more time invested up front.
Yeah, another question is, madam, many patients on ibrutinib, because of the toxicity, we have to discontinue the treatment. And if we offer them acalabrutinib, how is their tolerance compared to ibrutinib? Whether they tolerate it nicely or we have to shift them to a BCL2 inhibitors?
Yeah, so the first thing is if they've been on ibrutinib for a while and you have to stop for intolerance, I often try not to treat them for a while, just like see what happens, wait till they progress if they're in a good remission. Sometimes it's years, actually. But so there are data, though, that Acala and Xanu, we have data with both of them, actually, that are much better, are tolerated even in patients who stop ibrutinib for AEs. Like the rate of discontinuation, so the rate of recurrence of the same AE in this study with acala in the ibrutinib intolerant of any recurrence was maybe 25 or 30%, but it was usually a lower level, and discontinuation was only 10%. So they were able to stay on. Personally, I often it depends on the severity of the side effect, but if the patient, has really been kind of suffering, like I said, I like to give them a break, but if you do have to treat them, sometimes I just switch to venetoclax and then assume I can go back to acala later, because it's like a clean break with the side effects. I think it's sort of better for the patients kind of, emotionally, and then maybe also in terms of just letting the side effect resolve. And then if you start again later with the more specific BTK, they won't hopefully have the side effect. But it's fine to do the acala though. Lots of people do that too. I just sort of have this other approach.
Thank you, madam.
Rajkumar.
I am being the last one, more of a concluding remark rather than a query. So more and more we are moving, the treatment evolves, more and more we are moving towards the treatment strategy being followed in multiple myeloma with the deeper molecular response or deeper MRD is achieving with the help of chemo-free triple combination drugs, and trying to use our active drugs upfront and trying to achieve an undetected MRD as deeper as early as possible without much role for a transplant, starting the transplant in at least in the intermediate and the high risk patients. So these MRD positivity patients alone may be subjected to a transplant rather than the MRD negative. Am I correct?
Yeah, I think that's true, especially for sort of the young fit patients, especially with 17p deletion. Depending on what your access to drugs is, like we were just saying, if you can only get chemo, you probably want to do a first remission transplant for the very high risk patients. If you can access 2 targeted inhibitors, it's probably reasonable for them to have one until progression, and then they can get the other. But if they've progressed on a BTK and now they're getting ven and they're young and fit, and you don't really have something else is going to work, you probably do want to think about a transplant, especially for the ones with 17p deletion. If you have lower risk disease and they're just MRD positive, they can still get a few years remission, and then if you have other drugs to treat them, you can treat them again. So it really depends on, the biology of their underlying disease, how much you need to be worried about the MRD positivity. If you have a mutated patient with lower cytogenetics, a lot of times they don't progress that rapidly anyway, even if they're off therapy. So yeah, it just depends on the biology, I think.
Thank you.
Thank you. A couple of questions from the audience. If there's a 60-year-old fit patient with deletion 17p desires a limited frontline therapy of fixed duration, what would be your option?
Yeah, so, I might tend to favor ibrutinib venetoclax if you can get it, but we really don't have any data on that. That's really based on the idea that hopefully giving those 2 drugs will reduce the development of resistance later. And we don't really know that for sure, but that's the type of thing that we're studying in our trials currently. Ven-Oben did have a median PFS of 4 years. That's not bad. So you can still consider that. We don't even know what it will be with ibrutinib venetoclax. In Captivate and GLOW, so GLOW excluded 17p patients. Captivate had about 15% of them, but it looked like their outcomes were pretty similar to the rest of the cohort so far. That's short, and they didn't show a PFS curve. So we're kind of lacking data, but I would keep a close eye on that data and consider that option as the data emerges.
Thank you. Another question is, in a young, fit, relapse refractory patient who is resistant to both BTK and BCL2 inhibitors, will you go for allo transplant or enroll in CAR-T trial?
Yeah, so that's an interesting question. I think the bias of most people and most patients has been to try the CAR-T trial if you have access to one. Because, well, first of all, you have access to it now. and so you give it a try. If it works long term, then you're in good shape. If it doesn't work long term, you still have the allo later. That seems to be the preferred order compared to doing allo first and then having to worry about CAR T sort of generated from the allograft, probably. So.
Yeah. Another question is, do we know whether venetoclax with rituximab is inferior to venetoclax with Gazyva?
No, we don't actually know that. That hasn't been studied, but that is being studied in the CLL13 study, the German CLL study group, which I think we may get data on pretty soon, possibly as early as this year at ASH. I don't know that though, but they have Ven-R and they have Ven-Oben. Right now, the only head-to-head that we have is the chlorambucil, rituximab, chlorambucil, obinutuzumab, where clearly the obinutuzumab was better. I think most of us believe it is better, but we don't have that head-to-head data.
Right. Those were the questions from the audience. Do you want to take one or two more questions from faculty here?
I'm fine, yeah.
You're okay with it, Dr. Afak?
Ma'am, in the era of novel agents, do we still have a place for BR or FCR?
Well, I told you, I believe people are cured by FCR. And so, 40-somethings, 50-somethings with IGVH mutated disease, I think it's still quite reasonable. And if you think about, you want to get them through several decades of life with your available treatments, sometimes not giving up on a line of therapy is good, right? So if they have disease that biologically, they could get 5 to 10 years out of chemoimmunotherapy, I think it's quite justifiable to consider using it. It's 6 months, and then they can have a long duration off therapy and they still have their other therapies. It's not going to work after, I feel pretty confident it won't work after patients have progressed on BTK or BCL2 inhibitors. And we do have a little real world data that says that. But, there's a lot of excitement, obviously, about the targeted inhibitors. And in general, the side effect profile is better. But there's also something to be said for 6 months and getting 10 years. But again, there's heavy patient selection to make sure you use it for the patients who get the benefit.
Thank you.
Dr. Deepak?
This, basically, for my understanding, in patients who are combining anti-CD20 antibody with a BTK inhibitor, there is a lead-in period in which you give BTK inhibitors. What is the rationale behind it?
You're asking about the lead-in for the BTK, is that what you?
Yes.
Yeah, yeah. The rationale, there's actually quite a few studies that have demonstrated that you can substantially reduce the infusion reactions if you use the BTK inhibitor first. A lot of studies are now sort of doing a month, but it actually probably works if you give it even the same day, a few hours earlier, or certainly with a 1 week lead-in. So I think that's a lot of the rationale for that. We're now doing a study where we're delaying the antibody until month 7. And that's based, on the study from the UK that Andy Rostron presented, where they enrolled patients who've been on ibrutinib for at least a year, and they gave them obinutuzumab, and they found actually a much higher CR rate than we have if we give obinutuzumab up front when there's a lot of disease. So I actually think that's kind of interesting, using it later for consolidation. The PK of the antibody, we know it's much better when there's less disease. That hasn't been extensively studied, but I think that's interesting. But the main reason right now is the infusion reactions.
Thank you. Any other question from anybody? Okay, none. In that case, yeah, yes, Amit, yes.
In the current era, like in the last decade, there have been new novel agents coming up for CLL as well as for myeloma. Do we need a change in the classification rather than the usual RAI and the Binet staging in CLL, the comparison of the genetic, and to give us what or guide us about what would be the PFS, or to give the patient a timeline, like when exactly would be the next line of therapy, or what would be the survival advantage of one or the other? Like in myeloma, we have now standard intermediate and the high risk ones in 7. So something like that, and then and guide us the new novel agents in the pipeline, when what to be used.
Yeah, I think that would be very helpful. We don't, So it would actually even be good if we could include some data about the sort of common somatic mutations. We don't have that level of data yet. But, there is the CLIPI with the P53 and IGHV status, which are the most important. And so you can sort of think about the CLIPI in terms of risk stratifying your patients. And Mayo they just did a study they published in Blood where they looked at MBL patients and stage 0 CLL, where it also seemed to be sort of prognostic. It didn't really add a lot to IGVH and 17P. It didn't look like to me. They added white count. Unsurprisingly, the height of the white count matters for those patients. But I do think we're moving in that direction. I've actually almost thought that IGVH mutated and unmutated patients should be separate diseases. And I think, fortunately, the field is moving back a little in that direction as we're seeing the differences sustained with time-limited therapies, similar to what we saw with chemoimmunotherapy. But I'm not sure that there's going to be a change in the staging, but at least better prognostication, and at least we're seeing the studies stratified by these factors now.
Kurana?
Yes, ma'am. This may be a repeat one, but still I will present it. 88 years female, extremely frail patient, symptomatic CLL with deletion 17p and both TP53 mutated also. Has a history of coronary artery disease, on medical management on single agent aspirin. What would be your line of management?
Yeah, I would use acalabrutinib.
Acalabrutinib is not available here so frequently. So now between ibrutinib.
Do you have to use ibrutinib? Is your only BTK?
Can we go for Ven plus O in this?
Yeah, I mean, you can for sure. Yeah, yeah.
And second question, madam, have you seen any Stevens-Johnson syndrome due to ibrutinib? I have one patient started ibrutinib after 48 hours land up in Stevens-Johnson syndrome.
Yeah, so I wouldn't say I've seen anything quite that fulminant, but you can see Stevens-Johnson syndrome, a huge range of actual terrible skin complications from ibrutinib. I've had a lot of patients with paniculitis and erythema nodosum where it persists for years after stopping the ibrutinib and needs multiple lines of therapy to get it to resolve. So yeah, serious skin complications are a big problem with ibrutinib.
Okay, thank you, ma'am.
And Dr. Amit, acalabrutinib is available. AstraZeneca has marketed it quite some time ago. So you can contact them, and they have a patient assistance program also. Any other question, please? Okay. We have official vote of thanks from Dr. Micha.
Yes, thank you very much. It was really a very interesting lecture, a very interesting discussion. I have been writing a lot in my notebook, so I learned a lot. I can say definitely. I think like most people here, I think it has been very clear. If anybody had any doubts, CLL is not a boring disease. It is actually not a disease. It's actually it's a very complex combination of different diseases, if we want to look at it in this way. What I took maybe, and I don't want to go in detail, as I said, I really took many notes. So just maybe one thing that stuck to me is like, we're really going into a way where we're having a much more of a personalized situation. We want to have like really personalized therapies for the patients. We are having now the options. They are all coming up. If they're not yet available, they will be available very soon. And then when we think about the therapy, we have to investigate a lot. We have to understand the patient. We have to understand the disease biology, the mutations that might be available, might be around. We also have to know the preferences the patient might have. Does he or she want to have limited time therapy? Does she or he want to have a chemo-free therapy? What are the preferences in this sense? Other important things is like, we always look for efficacy. I think as a doctor, you always start, you want to treat, you want to cure, you start with efficacy, but you should never forget about the comorbidities that patients have. All of these things will influence what choices we do. And I think it's definitely a very exciting field. Now we have to make sure the patients, it has been mentioned a couple of times, actually can get access to these therapies. It is not sufficient to have them just on the shelf or have them for just part of the population. From our side, we definitely want to do all we can to contribute to this side to really make sure patients, independent of economic status, will have access to those therapies. I want to thank everybody for this excellent discussion, this excellent lecture. It was an honor to be part of it, to be sponsor of this event, which was organized in such a magnificent way from your side. Dr. Agarwal, Dr. Brown, and all the discussants. Great 20 from our side. Thank you.
Thank you so much. And once again, on behalf of Mumbai Hematology Group, I thank Dr. Jennifer Brown for accepting our invitation, sparing your time, educating us, interacting with the Indian colleagues. Many of them are fellows and students, and they benefited a lot from your lecture and discussion. We have participation from 11 countries, not only from Asia, but from even outside. And half of them are consultants, half of them are doing their post-graduation, and they all must have benefited. We have almost 400 plus registrations for your talk. Thank you, and have a wonderful day.
Thank you very much for inviting me. It was a pleasure.
Bye. Bye-bye.
Bye.
Bye.